Thank you for the invitation. It's my pleasure to give the last talk of the conference. And today I'll be talking about relapse and refractory myeloma and new treatments. I have no disclosures. There are three goals of this talk. First is to present general guidelines in approaching a patient with relapse and refractory multiple myeloma, then to review the approved therapies in the relapse setting, and finally to present new and investigational treatments with focus on immunotherapeutic approaches. Despite enormous treatment advances in myeloma, as Dr. Cowan alluded to, the vast majority of patients with myeloma ultimately relapse and die of progressive disease. Old data published 7 years ago reported dismal prognosis among patients who relapse after prior therapy with an immunomodulatory agent as well as a proteasome inhibitor, with an event-free survival of only 5 months and an overall survival of 9 months. Although updated results show improvement, survival remains poor, and another problem is that with relapse disease, there is shrinking treatment efficacy with each relapse, and the duration and quality of response decline. As we understand, multiple myeloma is a heterogeneous disease such that the biology of this patient's myeloma is not the same as this patient and not the same as that patient. And this inherent biological differences can be illustrated by the differences in the course of the patient's disease. This patient relapsed at these time points, which is typical of an average patient, whereas this patient appears to have more indolent disease with a relapse at a later time point. The third patient, on the other hand, illustrates a more aggressive disease with short responses and early relapses. This illustration shows that even within the same patient, a myeloma cell clone can branch out and evolve by acquiring additional mutations, and with each relapse, there's increasing genetic complexity, rendering the disease more resistant to therapy. The good news is that there are many drugs approved in myeloma, as listed here, with different mechanisms of action, and combining these drugs may augment treatment responses. The bad news, however, is that we have too many drugs and seemingly infinite drug combinations, but have nothing in terms of randomized trials to give us clarity on the optimal combination and sequencing of these agents. This table lists some of the pivotal phase 3 trials in the relapse refractory setting over the last 3 to 4 years, which reshaped the current landscape of myeloma therapy. A common theme in these phase 3 randomized studies was that patients who received a triplet regimen did better than those who did a doublet consisting of either bortezomib and dexamethasone or lenalidomide or dexamethasone. Therefore, triplet regimens is typically preferred if patients can tolerate it. So when do we treat relapse? Intuitively, patients who develop clinical relapse in the form of CRAB symptomatology, development of extramedullary disease, or secondary plasma cell leukemia warrant immediate treatment. However, in the case of biochemical relapse, treatment is typically initiated when there is evidence of significant increase in myeloma-specific labs in the blood or urine, as listed here. Several factors need to be considered before embarking on therapy. Patient-specific factors such as age, fitness, and comorbidities would inform a patient's ability to tolerate treatment. In terms of disease, more aggressive relapse with end organ damage or circulating plasma cells warrant highly active triple therapy, and in the case of patients with high-risk cytogenetics such as translocation 414 or deletion 17p, agents such as newer generation proteasome inhibitors, immunomodulatory agents, or monoclonal antibodies should be used. In terms of prior therapy, those who had a long duration of response of more than 6 to 9 months previously can be retreated with similar drugs used previously. And of course, toxicities as well as cost are important considerations in choosing the next line of therapy. As a transplant physician, I would like to mention that autologous stem cell transplantation remains an important treatment in the setting of relapse refractory myeloma. And the most important factor in predicting a progression-free survival benefit after salvage autologous stem cell transplant was the duration of remission from the first transplant. As a general rule of thumb, we offer reinduction followed by a second transplant in patients who have at least had 18 months of remission from the first transplant if they didn't receive maintenance, or longer if they were on maintenance. And among patients who chose to delay transplant in the beginning, transplant should be considered strongly at the time of relapse. We should remember that our early foray in immunotherapy space is with allogeneic stem cell transplant, and this is due to the graft versus myeloma effect. However, the application of allo transplant has been hampered by high rates of treatment-related mortality, as high as 50% in old studies. And with the use of reduced intensity or non-myeloablative regimens, the treatment-related mortality is lower. However, relapse is a problem. However, we do have some data suggesting that allogeneic stem cell transplant may benefit high-risk patients, and it should be considered in patients who are young, fit, in the context of well-designed clinical trials. I will say, however, that if allotransplant is considered, it should be offered early in the disease course because it has questionable efficacy later in the disease course. So what's new in myeloma? There are many drugs that are being developed right now. There are new proteasome inhibitors such as marizumib, which crosses the blood-brain barrier. There's oprozumib, which is an oral irreversible proteasome inhibitor. There's also a newer anti-CD38 monoclonal antibody called cetuximab with phase 3 trial data recently reported in ASCO of this year in combination with pomalidomide and dexamethasone, which have been shown superior progression-free survival as compared to pomalidomide and dexamethasone alone. What's also exciting is the development of daratumumab that can be given subcutaneously, and in a phase 3 non-inferiority trial, subcu daratumumab was found to be non-inferior to IV daratumumab, and this is very important because daratumumab administered subcutaneously will limit infusion times as well as decrease infusion-related reactions. Iberdomide, which I actually don't know how to pronounce, is a cereblon E3 ligase modulator which induces degradation of transcription proteins such as Ikaros and Aiolos, and these are transcriptional repressors of T cells. And iberdomide has been found to be effective even in patients who are resistant to lenalidomide as well as newer generation immunomodulatory agent pomalidomide. And selinexor is an inhibitor of nuclear export protein XPO1, which leads to the accumulation of tumor suppressor proteins within the nucleus, which promotes apoptosis. And it has been shown to be effective even in patients who are quad or penta-refractory to therapy. So now venetoclax is a medication that we are familiar with and has been used extensively in lymphoma and now used also in leukemia. It has shown promise in myeloma as a single agent in a phase 1 study in patients who have previously received a median of 5 lines of therapy. As a single agent, the response rate is actually promising at 21%. However, in patients with translocation 1114, who tend to overexpress BCL2, the response rate is more robust at 40%. When studied in combination with bortezomib and dexamethasone, we see a higher response rate of up to 67%. and very striking response rate among patients who are BCL2 high expressors, with an overall response rate of 94%. However, unfortunately, the results of the BELLINI trial, which is a phase 3 trial of venetoclax, bortezomib, and dexamethasone versus bortezomib and dexamethasone alone, which was recently presented at the European Hematology Association approximately 2 weeks ago by Shaji Kumar, it's disappointing because the rate of deaths were doubled, 21% versus 11%. Primarily due to infections. The overall response rate, as well as the progression-free survival, were improved with a combination and more, in particular, in patients with a translocation 1114. So as we know, the main target in myeloma right now is called B-cell maturation antigen, or BCMA. BCMA is primarily expressed on normal and malignant plasma cells, and it has been validated as a good therapeutic target. It binds the ligands APRIL and BAFF, which are required for plasma cell survival. So as I mentioned, there are many promising new therapies that target BCMA. One is this antibody drug conjugate, which is called GSK 2857916, which has a dual mechanism of action. It has a poison, which is called monomethyl auristatin F, which is a microtubule disrupting agent, which is internalized within the myeloma cell and causes apoptosis. In addition to that, it has immunologic mechanism of action, which promotes antibody-dependent cellular cytotoxicity, as well as antibody-dependent cellular phagocytosis. In an early phase study, which is a first-in-human study, demonstrated an overall response rate of 60%, with half of the patients achieving a very good partial response or greater, and the median progression-free survival was promising at 8 months, with the most common side effects including corneal events, such as blurring of vision, as well as photophobia and cytopenias, primarily anemia and thrombocytopenia. The myeloma community is also very excited about bispecific T-cell engagers, or BiTEs, which is attractive since it can be given off the shelf. It binds BCMA, which is found in the surface of multiple myeloma cells, as well as it binds T cells, and it's able to result in T-cell mediated cell lysis of BCMA positive myeloma cells. In a phase 1 first-in-human trial, 30% of treated patients had a response, and among patients treated at the MTD of 400 micrograms per day, there was a response rate of 70%. The common adverse events that were noted included cytokine release syndrome, neuropathy, as well as infections. Of course, we can't not talk about CAR T cells, and these are some of the CAR T cell trials in myeloma targeting BCMA. This is not an exhaustive list, and there are many other trials exploring BCMA CAR T cells. Note the differences between the studies' CAR constructs. What's striking, though, is that these studies provide early enticing data with observed responses, even among patients in whom no other reasonable options exist. And the results of the BB2121 study was just published last month in the New England Journal of Medicine, which I will go over with you. So the BB2121 study is a phase 1 study that consists of 2 phases, a dose escalation phase as well as an expansion phase. 21 patients were treated in the dose escalation phase and 12 patients in the dose expansion phase. These patients were heavily pre-treated with a median of 7 prior lines of therapy, and 45% of whom harbor high-risk cytogenetics. A total of 25 patients, or 76%, had cytokine release syndrome, which was grade 1 or 2 in the majority of patients, and grade 3 in 2 patients. 7 patients were treated with tocilizumab, and 4 patients were treated with steroids. Neurologic toxic effects occurred in approximately 14 patients, and the majority were grade 1 or 2. They found promising response rates at a rate of 85%. However, the median progression-free survival was short, only 11.8 months, telling us that more work needs to be done not only in making CAR T cells safer and more effective, but also making the responses more durable. Now, I'd like to mention that there are currently 2 BCMA CAR T cell trials at the Fred Hutch right now, led by Damian Green as well as Andrew Cowan. Both trials use this CAR construct. I'd like to note that in contrast to the BB2121, we use a fully human BCMA-specific single-chain variable fragment. We still use the same 4-1BB and CD3 zeta signaling domains, but in addition to that, we do have this truncated EGFR receptor, which we use for tracking, as well as a safety innovation that allows for elimination of CAR T cells in case we see significant toxicity, and we can use cetuximab in those patients. In addition, I would also like to mention that at our center, we use 1:1 ratio of CD4s and CD8s, as preclinical data generated at our center have demonstrated that CAR T cell products, which are derived from defined T cell subsets, have enhanced efficacy and potency compared to products which are generated from unselected T cells that vary in phenotypic composition. Lastly, I'd like to mention this trial by Andrew Cowan that incorporates a small molecule which is called gamma secretase inhibitor. We know that antigen loss and downregulation has been reported as a common mechanism by which tumors escape CAR T cell mediated cytotoxicity. As we see in this cartoon, this is the gamma secretase, which cleaves BCMA, which is found in the surface of plasma cells, and releases soluble BCMA into the circulation, which would then inhibit recognition by the CAR T cells. The hypothesis is that when we use gamma secretase inhibitor, we will increase BCMA target density and further enhance CAR T cell recognition and subsequently the function of CAR T cells. I would like to end with the following key points. As we know, we do have effective treatments for relapse and refractory myeloma. However, we still don't know how to optimally sequence or combine these medications. It is very important to individualize treatment, basing decisions on patient disease as well as treatment-specific factors. And know that it is an exciting time in myeloma right now with the development of targeted therapy, immunotherapy, and other drugs with different mechanisms of action. So stay tuned for more results. Thank you very much for your time.
Thank you for excellent overview about management of relapse and refractory myeloma. Any questions from audience? So, like for example, if I have a young patient, like 35 or 40-year-old, What would be the first line of therapy after RBD?
And the patient doesn't have any sign. Well, first, I would like to know what kind of relapse the patient has, if it's a clinical relapse versus
So this patient has primarily biochemical relapse. M protein went up by 50%.
Okay.
And does not have any other new bone lesions
Okay.
or the hematologic manifestations or calcium hypercalcemia.
Okay. And any high-risk features?
So his cytogenetics shows high risk genetic features.
Okay. And did the patient have a transplant?
Nope.
Okay. Why not?
So one of the major issue with transplant is tons of patients, including my patients, who I tend to refer those patients early on for transplant, and they read on Google, the Google Doc, right? So it is controversial. So it is very hard for them to kind of, even if you go to some decent websites, medical websites, they write that very single statement. It is, the role of stem cell transplant in multiple myeloma, frontline treatment, is controversial. And with that kind of language, verbiage on internet, anybody can search.
Well, I guess the most important thing is to re-educate our patients that actually autologous stem cell transplant in 2019 is still not it's not controversial. You know, we still don't know whether there's an overall survival benefit based on the ATOL data published in 2017. However, we do know that the progression-free survival benefit is significant of 14 months difference. And this duration of remission or the progression-free survival benefit would allow patients to have the opportunity to have more novel therapies down the line. So I guess I would first counsel the patient that it's not controversial. Allotransplant is controversial. Autologous transplant is not controversial, and this is something that we would still offer to our patients because even if they don't respond to highly novel therapies, it does not preclude that they wouldn't respond to an alkylating agent such as melphalan. I believe that melphalan is still a very powerful chemotherapeutic agent for myeloma. So I would first reconsider reinduction, possibly with KRD. Carfilzomib or even carfilzomib pomalidomide or even daratumumab-based therapy. And after I've achieved a decent response, I would refer for a salvage autologous stem cell transplant.
Sure, thank you. Now, I have another question about a patient with amyloidosis.
I'm not an amyloid person. But
so I know
sure.
it is. So this gentleman, he came to my office because he had nausea, vomiting, and diarrhea, all the weight loss and all that. He was given EGD, colonoscopy, and they did biopsy, and he had this amyloidosis. Echocardiogram, and they were all negative for cardiac involvement. How would you manage this patient as first-line treatment?
This is confirmed.
I wanted to send this patient for mass spectrometry to Mayo Clinic. We did not have enough tissue, but he had light chains and all other features suggestive of light chain amyloidosis.
And we can't biopsy anything?
So we would have to do another repeat EGD, I guess.
Mm-hmm, mm-hmm.
That would be one option.
Yeah, I would say maybe just confirm the diagnosis of amyloid and send tissue to the Mayo Clinic for mass spec to confirm diagnosis of AL amyloidosis and perhaps treat with just the usual Cyborg-D.
Okay. Sure. Do you see improvement in their GI symptoms in your practice with treatment?
Just full disclosure, I am actually a transplanter. I don't see
I see. Okay.
amyloid patients in clinic.
Sure, because I was going through some of the literature, and that seems to be one of the toughest symptoms to treat in amyloidosis.
I agree. Cardiac amyloidosis is one of the poorest prognosis in amyloid. So I agree, it's something that is difficult, and still we definitely need new therapies for amyloidosis, especially when it involves the heart.
Sure. Do you transplant those patients, some of those amyloid
Some of them,
patients?
yes. They just proceed with
Sure.
transplant, yeah.
Any other questions for anybody? No? Perfect. Well, thank you all for being here. And this concludes the ICAHO 2019. We'll see you back next year. Thank you.